and the topic is, should postprandial hyperglycemia be treated to targets? The human brain starts working the moment you are born and never stops until you stand up to speak in public. And I put it slide to add, especially after Verghese Thomas sir. It's very difficult to stand after a talk by Verghese Thomas. So you all enjoyed it. Now we'll see, should postprandial hyperglycemia be treated to targets? The link between hyperglycemia and diabetes related complications, PPG and its contributions to glycated hemoglobin, and the role of postprandial glycemia as an emerging therapeutic target. Insulin secretion and action. When we talk of postprandial hyperglycemia, the regulation of postprandial plasma glucose is highly dependent on the qualitative and quantitative aspects of meal-mediated insulin secretion as well as by the sensitivity of muscle to insulin action. So this is the normal physiology, and if you have meal, there is insulin and this hyperglycemia is tackled, and this is happening in every normal person. So this is what happens in a normal individual. So there is first phase of insulin secretion, and this immediately shuts the hepatic glucose production, and then the second phase of insulin that takes care of the post-meal related hyperglycemia. But in a type 2 diabetes patient, this first phase of insulin secretion is blunted and the second phase is rather delayed. So that produces sometimes pre-meal hypoglycemia, which is sometimes we call it as reactive hypoglycemia, that can happen even in people with established type 2 diabetes mellitus. So this is a depiction what happens when there is a postprandial glucose spikes in a person with type 2 diabetes mellitus if we don't tackle it appropriately. So this is a cartoon. In fact, this has been made by 2-3 articles that has come in this aspect. We have a post-meal spike with breakfast, lunch and dinner. On all this together, this post-meal glucose spike produces oxidative stress, and this results in inflammation, endothelial dysfunction, and possibly this is the cause that says that postprandial hyperglycemia is the reason for increased cardiovascular event in a patient with type 2 diabetes mellitus. This is another slide that's showing what it is very difficult to understand at this evening time of the day. This says that there is hyperglycemia that has effects through the mitochondrial chain, produces peroxynitrite, and it results ultimately into endothelial dysfunction and diabetes complication. We'll see in a simpler way so that we'll understand it. So there is hyperglycemia that acts through the mitochondrial electron transport chain. There is superoxide overproduction by the mitochondrial electron transport chain. There is increased production of peroxynitrite that results in DNA damage, activation of PARP, and this ends in endothelial dysfunction, and this is supposed to be the mechanism by which a person with high post-meal glucose load in a type 2 diabetes is susceptible for increased cardiovascular risk. So this is otherwise known as postprandial dysmetabolism. There is hyperglycemia and hyperlipidemia. So there is increased inflammation, endothelial dysfunction, decreased fibrinolysis, plaque instability, and cardiac events. There is direct and proportional association with both coronary artery disease and cardiac events in a patient with type 2 diabetes mellitus. And this postprandial dysmetabolism is causing hyperglycemia as well as hypertriglyceridemia. This leads to oxidative stress and endothelial dysfunction. So there are many intervention studies which states that this is associated with increased cardiovascular disease. And among them, the most important one is probably STOP NIDDM trial, where acarbose was used in impaired glucose tolerance patients, and it has clearly shown that there is a 36% reduction in the risk of progression to diabetes. So in fact, this is a drug that we can prevent the development of diabetes mellitus. 34% risk reduction in the development of new cases of hypertension, and 49% risk reduction in cardiovascular events. So if you address postprandial hyperglycemia appropriately, there is a chance that we could prevent the future development of cardiovascular events in these patients. So there are many studies that links the morbidity and mortality related to postprandial hyperglycemia of this. Some of them has tried oral glucose tolerance test, and some have just looked at the blood glucose values at 1 hour or 2 hours, and this was looking at either the cardiovascular events, all-time mortality, or some of them were looking at carotid intima media thickness, which is considered as the surrogate marker of endothelial dysfunction. So these are all studies: Hoon study, Honolulu, Chicago Heart, DCODE, all were looking at the same thing, and they have been addressing the risk of cardiovascular disease and mortality in patients with postprandial hyperglycemia. So this is the slide that we have already seen. There is first phase of insulin secretion and there is second phase of insulin secretion, and this first phase is blunted in type 2 diabetes mellitus patients. So this, it's only to show that there is relative risk for death increases with 2-hour post-meal glucose irrespective of the fasting plasma glucose. So as the fasting plasma glucose moves, whatever be the fasting plasma glucose, there is an increased risk of death due to cardiovascular disease in a patient if there is increased post-meal glucose. The post-meal glucose is primarily deciding the cardiovascular risk in patients with type 2 diabetes mellitus. So this is another interesting slide which shows that impaired glucose tolerance is a CV risk factor. What we see is this is the patient with this is the impaired fasting glucose, and this blue is the impaired glucose tolerance. In fact, the impaired glucose tolerance curve is moving along with that curve of type 2 diabetes, and impaired fasting glucose is rather along the curve of the normal glucose. So this says that if you have an impaired glucose tolerance, it is almost equivalent to that you are going into the stage of diabetes, and it also says that there is an increased risk of cardiovascular events, and cumulative cardiovascular survival is more in those patients with normal blood glucose and as well in patients with impaired fasting glucose. So now we will see what is the relationship between HbA1c and fasting plasma glucose and postprandial glucose. This is an old slide, and this has shown many times, and this shows that these black bars are in fact the contribution from the fasting glucose, and white bars are the contribution from the postprandial glucose. So as we move from better HbA1c control, the predominant contributor is the postprandial glucose. If you have a patient with high HbA1c, we go with the fasting blood glucose as the target for treatment, and that is why we call it as fixed fasting first. So once we control the fasting and then we move to HbA1c less than 8%, probably we will have to target more on the postprandial glucose to get the better HbA1c in these patients. This is the same graph that shows that this red is the postprandial load and yellow or this golden is the load by the fasting glucose. So as the HbA1c higher, the predominant contributor is fasting plasma glucose, but as we move into the better glycemic control into an HbA1c less than 8%, the predominant contributor is the post-meal glucose. So this is what it says. If you would like to have an HbA1c of less than 6.2, 6.8, we have to target more of the post-meal glucose, but the contribution to this will be less as we move on to higher HbA1c. So what are the approaches or agents that we have to tackle this post-meal hyperglycemia? We have meglitinides, that is ripaglinide and natiglinide, alpha glucosidase inhibitors, prandial insulin, GLP-1 analogs, DPP-4 inhibitors, pramlintide, and dietary interventions by patient is asked to look at the glycemic index and glycemic load, and if they could modify it appropriately by self-monitoring of blood glucose, that is also a useful way to tackle the postprandial hyperglycemia. So this is a slide that has come in 2002. we were having at that time sulfonylurea, ripaglinide, metformin, rosiglitazone, pioglitazone and alpha-glucosidase inhibitors, and it clearly shows that ripaglinide and natiglinide as well as alpha-glucosidase inhibitors are the drugs that brings low the post-meal or postprandial blood glucose and bringing down the HbA1c. This is the comparative profile of agents for managing postprandial hyperglycemia. This is insulin lispro, that's a rapid-acting insulin analog, pramlintide, alpha-glucosidase inhibitors and ripaglinide. So the benefit goes with alpha-glucosidase inhibitors because it has moderate potency and it do not produce hypoinsulinemia, weight gain, hypoglycemia, but definitely with some gastrointestinal side effects. So this is how this drugs is effective in tackling the postprandial hypoglycemia. So these are competitive reversible inhibitors. The drugs currently available are acarbose, miglitol and voglibose, and the dose is 0.2 mg 3 times daily, may be increased to 0.3 mg with food. And it has many mechanisms for postprandial hyperglycemia. It decreases postprandial hyperglycemia, hyperinsulinemia and improves insulin sensitivity. It acts on the early phase of insulin secretion, increases the overwork of pancreatic beta cells because it reduces the hyperinsulinemia, reduces visceral fat deposition, and probably it mobilizes the endogenous pool of GLP-1 and does not induce hypoglycemia and has a good safety profile. So that is the major attraction of this group of drugs because it do not produce hypoglycemia, especially when it is used alone. But along with drugs that produce hypoglycemia, we have to be cautious. So this is what happens when you give voglibose. There is a significant reduction in both postprandial blood glucose and the HbA1c, especially if you would like to bring down the HbA1c to near normal in a patient with type 2 diabetes mellitus. Another option for tackling postprandial hyperglycemia is rapid-acting insulin analogs, especially in those patients with advanced diabetes mellitus, where you could go with a rapid-acting analog with 3 shots with each meal so that we could take care of the postprandial blood glucose spikes. And what we have in the newer insulins or bolus insulins, there are many investigational drugs that is currently going to come to the market, and maybe we will be having this in another 2 to 3 years because we are not really happy with the rapid-acting analog with regard to the post-meal blood glucose control. So there are many investigational prandial insulins are available, including Technosphere inhaled insulin, Evrisa, or faster aspart, otherwise known as FIAS. So probably we might move from these old inhaled insulins to situations like this where patient may be moving around with an inhalation therapy as we see in bronchial asthma. So this will be a really good option, especially in those patients who would like to avoid each prick with pre-meals. So along this to have a better HbA1c, we have to achieve the targets by blood glucose monitoring, self-monitoring of blood glucose, and there are emerging technologies to tackle the postprandial hyperglycemia like continuous glucose monitoring system and 1,5-anhydroglucitol. So this 1,5-anhydroglucitol is a naturally occurring dietary polyol. It has been proposed as a marker for post-meal hyperglycemia because it is sensitive and responds readily to changes in serum glucose. It accurately reflects transient elevations of glucose within a few days. But as of now, there are no outcome studies as we have with HbA1c, with DCCT and UKPDS studies. We don't have outcome studies using the 1,5-anhydroglucitol. This is interesting. We see HbA1c, if the HbA1c is low, we say that the blood glucose control is not good. But in 1,5-anhydroglucitol assay, it is reabsorbed in the renal tubule with competitive inhibition by glucose. So when there is high glucose, the 1,5-anhydroglucitol reflects glycemic excursion. If it is low, if the 1,5-anhydroglucitol is high, we say that the blood glucose control is better as against the other values that we use as in HbA1c or blood glucose. So this is an intermediate term monitoring of glycemic control in patients with moderate to well-controlled diabetes Low levels of 1,5-anhydroglucitol primarily reflect postprandial hyperglycemia. And if you have an anhydroglucitol above 8 or so, we can say that the patient has got a better glycemic control. And it changes more rapidly than HbA1c level, and it reflects glycemia over a period of 1 to 2 weeks. So, what will be the clinical scenario where you will have to deal with a patient with postprandial hyperglycemia? All of us are seeing patients, and we will be seeing a patient like this. A 55-year-old male, otherwise healthy, obese, BMI 32 kg per meter square on glibenclamide, metformin with a fasting of 96 and postprandial blood glucose of 230 mg per deciliter, and he has got an HbA1c of 8%. If you would like to bring down this HbA1c to lower, like 7 or even less, definitely we have to have a drug that tackles specifically the postprandial blood glucose levels. So these are the recommendations. If you want to have an HbA1c less than 6, we should go to near normal, like less than 100 and less than 140. So to this level, if you want to have a glycemic control, probably we'll have to tackle the postprandial hyperglycemia in a better way. So the conclusions are: cardiovascular diseases are the #1 cause for death and disability in people with type 2 diabetes mellitus. Postprandial excursions of blood glucose may be involved in the development of diabetes complications, particularly but not only cardiovascular complications. The goal of diabetes therapy should be to achieve glycemic status as near to normal as safely possible in all the 3 measures of glycemic control, namely HbA1c, fasting, pre-meal and post-meal plasma glucose. Within these parameters and subject to the availability of therapies and technologies for treating and monitoring postprandial glycemia, a 2-hour postprandial glucose goal of less than 7.8 millimoles per liter, that is 140 milligram per deciliter, a difficult target if you really want to achieve it, is both reasonable and achievable. Regimens that target both fasting and post-meal glycemia are needed to achieve optimum glycemic control. Although cost will remain an important factor determining appropriate treatments, controlling glycemia is ultimately much less expensive than treating the complications of diabetes. If you really look at the complications of diabetes, I think we should be more stringent in achieving the blood glucose targets so that the patient will have a less risk for long-term comorbidities. So these are the real glycemic goals for clinical management of diabetes that we will be aiming for, with an HbA1c less than 6.5, pre-meal or fasting less than 100 and a 2-hour post-meal less than 140 milligram per deciliter without producing hypoglycemia. So to conclude, helping others is good and teaching them to help themselves is better. I have talked this slide over and over again, and this is what we do with diabetes management. But it is not enough for the physician to do what is necessary, but the patient and the attendants must do their part as well, and circumstances must be favorable. So that is also we have to remember when we really manage diabetes, and this was told by none other than Hippocrates. Thank you for your kind attention.
Thank you, Dr. Gossi and Dr. Chandni for the excellent talk.